Welcome, everyone, to another special episode of Arthritis Consumer Experts #CR Arthritis series from the Canadian Rheumatology Association's annual scientific meeting. I'm Kelly Lenvoy, and today I'm joined by Dr. Michelle Batthish, a pediatric rheumatologist at McMaster Children's Hospital, an associate professor of pediatrics at McMaster University. Her clinical and research interests are in healthcare transition in patients with chronic rheumatic disease and quality improvements in pediatric rheumatology. Dr. Batthish, welcome to the show.
Thank you for having me here.
Now, I know you're having a couple of posters that you're presenting. I'd like to focus on one of them today that's titled The Association Between Body Composition and Treatment and Disease Outcomes in patients with JIA. Your study found that children with JIA who are obese took longer to reach disease control despite earlier treatment. Why do you think obesity affects treatment responses and disease outcomes?
It's a great question, Kelly, and there's probably not a simple, straightforward answer to it. It's likely multifactorial, given that obesity is a multifactorial condition as well. So there are several theories, one of which we know is that obesity can lead to a state of inflammation. And so it is perhaps the cause of why these patients may need earlier treatment escalation because they have more active disease. And it's perhaps also the reason why it took longer for them to reach inactive disease. But that's just one theory, and there are likely multiple other reasons for these findings that need to be explored further.
Now, interestingly, on the other end of the spectrum, your study also found that underweight children required earlier biologic treatment. What challenges does this class of children and patients with lower body weight face in managing their JIA, and why might they need more aggressive treatment?
We were surprised with this finding because it wasn't something that we were expecting to see. And so again, there may be multiple reasons why children with JIA who are underweight needed earlier treatment escalation. And so is it possible that maybe we are picking up active disease easier in patients who are underweight? Is it possible that they are underweight because they have another inflammatory condition in addition to JIA, such as inflammatory bowel disease, which we know can present with poor weight gain, or celiac disease, another autoimmune condition, which again can lead to poor weight gain when it's undiagnosed at first. So again, we need to really dive into those reasons and potentially understand what else is going on in this patient population that is leading to earlier treatment escalation with biologic therapy.
Well, it's incredible research. Congratulations. I'm just wondering now, in terms of real world application, how can families and healthcare providers use these exciting findings to better support children with JIA in helping them achieve better disease control?
So I think the first step as researchers and healthcare providers is to really understand the meaning of this data. And so as a next step for us, we will be looking at other potential confounders. And so in those patients who are either overweight or underweight, what else could be driving this effect that we're seeing? You know, is there a difference between boys and girls? Is there a difference between the ages, you know, younger versus older patients? So we could potentially look at this data a little bit, or we will be looking at this data a little bit more closely in the next phase of this study. However, beyond that, at this point, what can we do as healthcare providers when we do see our patients in clinic? I think first and foremost is continue to provide ongoing management to our patients to the best of our abilities, despite their weight status, but also continuing to counsel our families and patients on healthy, active living and maintaining an ideal weight, but to really understand what else is going on in the patient's social, psychological environment so that we best support our families the best we can so that they have the best outcomes with regards to their JIA.
As you know about Dr. Batthish, we're doing a lot of work in the area of health inequities. And when you talk about the different sort of subtypes for JIA, and we think and talk about, social determinants of health, um, I think it's interesting that in terms of where you're going in terms of next steps of your research, to take a look at that, because certainly what we're finding um, as it relates to health literacy, as it relates to the role of ethnicity and the BIPOC subtype population. Um, these are these are areas that I think we're really excited in terms of what you're going to be able to find.
Yeah, and it's a great time right now within the pediatric rheumatology research community because there are multiple projects that are ongoing amongst my colleagues looking at healthcare disparities in this patient population, the geographic distribution of our patient population, and how far are they from the major pediatric centers in the country. And how all of that leads to potential changes in disease activity. Outside of the disease physiology itself, there are so many other components that affect how patient outcomes behave. And so we need to explore beyond just the numbers of, BMI or active joint count, et cetera, but consider the patient as a whole in its community.
Congratulations again on the research. We're going to provide links at the end for people to find out more information. And we're really looking forward to be able to continue this dialogue with you as you advance your research. So thank you so much for joining us today, and good luck at the conference.
Thank you so much. It was great chatting with you.
And thanks to all of you who joined us today. And we hope to see you again on another episode of hashtag CR Arthritis at the uh, Canadian Rheumatology Association's annual scientific meeting. I'm Kelly Lenvoy. Bye for now.